We're going to start by talking about oxygen therapy. Most people know at least something about oxygen therapy because they've probably used it their whole career. But we use oxygen therapy to avoid hypoxemia. Hypoxemia meaning the lack of oxygen. And people have an amazing ability to compensate for low oxygen levels. People have climbed Mount Everest where the oxygen partial pressure is so low you wouldn't think you could survive, but people manage. People fly on jet airplanes where the aircraft are pressurized to altitudes between 6,000 and 8,000 feet. And granted, they're not usually exerting themselves, but people tend to compensate for it. And if they were to check their saturations, most people, their saturations would not fall even with that altitude. In any case, we consider someone hypoxemic for our purposes if their pulse oximetry saturation is less than 90%, or if their arterial PO2 from a blood glass is less than 60. You also have to take into account context, because having a PO2 of 60 on room air is not so big a deal, particularly in an older patient, since the normal values tend to be lower than they are for a younger patient. But having a PO2 of 60 if you're breathing 80% is a big deal and will be significantly hypoxemic. Another factor that is frequently missed by pulse oximetry is that if you hyperventilate and lower your arterial PCO2 by hyperventilating, the PO2 will come up. So if you do that blood gas and the PO2 is say 60 or 70, but the PCO2 is blown off down into the 20s, then that person is working pretty hard to get that oxygen level. More or less, for every millimeter drop in PCO2, you will raise the PO2 by a millimeter as well. So that person with a PCO2 of 20 and a PO2 of 60 while hyperventilating, if they were not hyperventilating, perhaps their PO2 would only be 40. And that person might even have some respiratory alkalosis. And when the pH is higher, that shifts the oxyhemoglobin dissociation curve such that the saturation for a given PO2 will read higher than it would normally. In a person with a normal pH and a normal PCO2, if the PO2 is 60, pulse oximetry should read about 90%. But if the person is alkalotic, maybe it's going to read 92 or 93. So that person that is hyperventilating and the pulse ox says 93% and the PO2 is above 60, maybe they're actually hypoxic and need to have additional supplemental oxygen. So it's just something to consider if the patient's not doing well. That pulse oximetry is not always the end all, is certainly not the gold standard for determining if somebody is hypoxemic, because it cannot take into account shifts in the oxyhemoglobin dissociation curve that are caused by alkalosis, and it cannot take into account hyperventilation or the FiO2 that is needed to achieve that increased saturation. In any case, to qualify for home oxygen, you need to have a pulse oximetry less than 90% for people that have heart failure or COPD, and less than 88% for people that don't. But for practical purposes, we don't send people home with oxygen if they can maintain a saturation over 90%. If the saturation drops with exertion, then maybe they'll need home oxygen for exertion. But that's enough about that. Now, what about delivery methods? The most common delivery method is a nasal cannula. A nasal cannula, as you know, goes in the nose, and we set a fixed number of liters per minute to flow through the nasal cannula. About the maximum through a traditional nasal cannula that you want to use is probably around 5 or 6 liters per minute. What FiO2 is delivered, that's a little hard to say, because the amount of oxygen delivered to the patient is fixed based on what you put on the flow meter, but the amount of air mixed with that oxygen is set by the patient. So a patient that is hypoventilating and has 2 liters per minute by nasal cannula, the percentage of oxygen he is breathing is higher than the person that is hyperventilating. For example, a normal person breathes a minute volume of about 5 liters a minute. So 5 liters a minute of air, of which 2 liters is oxygen, gives you a certain FiO2. We could do the math, but not necessary. That same person, if they're breathing 20 liters a minute with that 2 liters of oxygen, obviously is getting a lower percentage of inspired oxygen. This is why, and sometimes with people with CO2 retention, such as COPD patients that are chronic CO2 retainers, their minute ventilation may be lower, and as a result, they will require lower liter flow settings on a nasal cannula to deliver adequate oxygen saturation. And if the saturation gets much above 93% or so, this will create some VQ mismatching, which may lead to CO2 retention, which is undesired. In general, with patients that are not significantly hyperventilated and don't have other factors such as severe anemia, we would like to target oxygen saturations in the intensive care unit in the 92 to 94% range. Interestingly, there was a study a few years ago in patients with acute coronary syndrome and unstable angina and myocardial infarction, and people that had their oxygen saturations maintained in the upper 90s had a higher mortality and larger size of myocardial infarct and dead heart muscle than the people maintained with oxygen saturations in the 93 to 94% range. The protocol for years has been to give oxygen to every angina patient, but now this needs to be adjusted based on the saturation just to the minimum amount of oxygen necessary to keep the saturation in that 93-94% range, particularly in the cardiac injury patients. If the liter flows get much above 5 or 6 liters per minute, the nasal cannula oxygen is very dry and, aside from being uncomfortable, can lead to nosebleeds. That's usually why we try to use heated high-flow oxygen systems for higher flow rates than 6 or 8 liters per minute to protect the nose from nosebleeds. The disadvantage of nasal cannula oxygen, aside from nasal irritation, of course, would be somebody that has nasal obstruction. I should note that you really don't need to breathe through your nose to take advantage of nasal oxygen, because even breathing through your mouth, the negative pressure is generated in the nose and oxygen does flow, and oxygen does fill the back of the throat and becomes the first part of the next breath someone takes. So there's not a lot of point in encouraging a patient to breathe through their nose. That pretty much takes care of itself. The other problem is you really just don't know what the FiO2 is with a standard nasal cannula. When the liter flow, again, requirements for hypoxemia treatment exceed 5 or 6 liters per minute, you're better off using one of the high-flow nasal cannula systems where you can at least set on FiO2 and you can add some heated humidity for comfort. People talk about the heated high flow as if the heat is the therapeutic part. The heat and the humidity is mainly to avoid complications. It doesn't make the oxygen work any better. It's the high flow that leads to the better oxygenation. A vapotherm is a heavily marketed, very expensive device that also provides heated high flow oxygen at higher levels. Some people say that using this actually adds a little bit of end positive airway pressure, much like putting somebody on PEEP on the ventilator or CPAP, but the level of pressure generated by the high flows on these devices is probably only in the 3 or 4 centimeter of water range at best. That can help some, but it's not that great a shake. The other claim for using these is to wash out the dead space so that the first part of the breath the patient breathes in has 100% oxygen, while later breaths are a mixture of the air they breathe in from the room plus the oxygen they obtain from the high-flow nasal cannula device. If high-flow oxygen at FiO2s of 60% or less are not sufficient to maintain the target saturation in the low 90% range, we do have to think about adding positive pressure, usually initially through use of a BiPAP device. The extra positive pressure can help combat atelectasis and low residual volumes to help prevent shunning and create better oxygenation at lower FiO2s. We'll get back to why the low FiO2s are important in a minute. People that cannot maintain adequate oxygen saturations on BiPAP at reasonable pressure settings in the 60-70% range, you have to consider the possibility of intubating or proning or other maneuvers to improve their oxygenation. When we use BiPAP for oxygenation, the EPAP setting, or expiratory positive airway pressure, is generally what correlates better with oxygenation than the inspiratory pressure. The difference between inspiratory and expiratory pressure controls the tidal volume, while the expiratory pressure is what helps provide better oxygenation. So typically, if you're putting somebody on BiPAP for hypoxemia, you want the EPAP somewhere in the 8 to 10 centimeter of water range, with the inspiratory pressure, the IPAP, somewhere in that 10, 15 to 20 range, depending on their need for additional ventilation. So what about Venturi mask? A Venturi mask has a Venturi device that has a nozzle that the oxygen flows through and side holes along the side. That nozzle accelerates the flow of oxygen, causing the Bernoulli effect. You can look that up, but that drops pressure near the air intakes, and air is entrained in and mixed with the oxygen at a fixed ratio. There are different adapters for different FiO2. For example, pink is traditionally for 40% oxygen, and 60% oxygen would be a 1-to-1 mix of air and oxygen. A Venturi mask is a means of delivering a known and fixed FiO2 based on a fixed ratio of air and oxygen. The total flow to the mask needs to be at least 40 liters per minute. Maybe 10 liters comes through the Venturi device through the jet, and another 30 liters of air is entrained to generate roughly 40% oxygen in that case. Turning up the flow or turning down the flow does not change the amount of oxygen the person gets, but it does change the total amount of airflow, including oxygen, that is delivered to the mask. If the flow is turned too low, then the patient will entrain air from the room and will not receive the FiO2 labeled on the Venturi device. There are different adapters, usually in different colors, to signify the different FiO2s. Pink is 40%, for example. When you're on a 24% Venturi mask, you're actually getting 1 liter of oxygen plus 20 liters of air. That's the ratio. I just remember that for some reason. 31% is something like 10-to-1, and 40% is somewhere around 3 or 4-to-1. I don't remember. 60% is a 1-to-1 ratio. And a 60% mask is difficult to get the 60% because unless you can get 40 liters total going through the mask, it's likely the patient is going to entrain some room air. So that's what Venturi masks are for. A simple mask is much like a cannula, but you do need at least a minimum of 3 liters a minute to wash the CO2 out of the mask. The FiO2 is unknown and varies like a nasal cannula based on the amount of airflow that the patient draws in around the mask. Non-rebreather masks, those are okay for use on the ambulance ride into the hospital, but should almost never be used in the hospital. Their intent is to try to deliver 100% oxygen, which, as you know from our other lessons, we never want a patient to be on 100% oxygen for reasons we'll get into elsewhere. So if someone's on a non-rebreather, that should be just to give you time to go get a high-flow cannula or to get a BiPAP device or to get them intubated. Don't let somebody stay on a non-rebreather mask more than an hour, because that's just negligent. And what about proning? Proning was not invented for COVID. I was proning patients back in the 1980s with ARDS, so it's a very old technique that had kind of fallen out of favor just because of the workload and people got lazy about using it. But proning helps improve the ventilation perfusion matching. Patients that have been lying on their back for a while, particularly that have edema or pneumonia in the dependent portions of the lung, which is most of them, get a lot of shunning because most of the blood flow goes to the bases of the lung. And if most of the ventilation goes to the upper part of the lung where there's not so much blood flow, then you create shunning, so because that blood that goes to those lower lobes comes back without oxygen because those areas aren't ventilated. So when you prone a patient, you improve the ventilation to those areas. You also let areas of pneumonia drain out, and areas of edema can shift into lesser perfused parts of the lung. So proning almost always works to reduce FiO2 requirements and should be done particularly in cases where FiO2 requirements are up in the 50-60% or higher range to try to avoid the oxygen toxicity issues. The length of time spent prone just depends on how sick you are. If a patient is going to crash when you go supine, then some patients, as you probably recall, have to be prone 24/7, sometime for days at a time. And certainly there can be some complications and pressure wounds, but you get those on your back too. You just get them in different places. You can do most all of the care maneuvers with the patient prone. You can certainly take the chest x-rays while they're prone. Central lines, occasionally you can do in the neck. I know we've done a few cases like that. We usually try to have at least 3 or 4 hours in the morning with the patient supine just for nursing care purposes and to make it easier to do those things that are just simpler when a patient is supine. But obviously if the person's going to be hypoxemic or require 100% oxygen to do it, that time has to be limited. So why is oxygen bad for you? Oxygen is bad for you in about 3 ways I can think of. I already mentioned in CO2 retainers that increasing FiO2 can cause VQ mismatch problems that can lead to excessive CO2 retention, and excessive CO2 retention can lead to CO2 narcosis, leading to more CO2 retention. It's not a matter of suppressing the respiratory drive, but it does change the efficiency of the lungs at getting rid of CO2. Number two is a big one that actually was responsible for a lot of COVID deaths. The high FiO2s cause oxygen toxicity. It turns out if you put a rat in a 100% O2 environment, they will die within 24 to 48 hours because they develop pulmonary fibrosis from lung injury from free radicals that are a part of all oxygen that we breathe. Humans have enzyme systems to scavenge these free radicals. Free radicals are things like O1 and O3. You've heard of O2, which is stable, but O1 and O3 are not stable. And O1 and O3, anything they touch, they can't change the chemical structure of, which if it's in your lung tissue, that creates damage. And when you're on high FiO2, meaning over 60% oxygen for much more than hours or days, then that will lead to fibrosis that is not reversible. We had many people that survived the initial COVID infection and survived the ARDS and inflammatory cascade, but eventually succumbed to respiratory failure because they developed irreversible lung fibrosis caused by high FiO2s and high oxygen concentrations. So we always want the oxygen concentration to be at the least amount that will maintain saturations in that 92 to 94% range that I mentioned earlier. This means including on the night shift. It's very disappointing to come in the morning and find that someone had an oxygen saturation of 100% for 8 readings in a row and remained on 100% oxygen for 8 readings in a row. That's just lazy. Anytime you see an oxygen saturation of 100% on somebody on oxygen, no matter their diagnosis, that means you need to turn the FiO2 down right now. You keep turning it down until the saturations are reading in the low 90s. If they desaturate, you turn up temporarily, but you don't just leave it there. You put it back. You always want to have the person at the edge of hypoxemia to avoid that direct toxicity from the oxygen effect. This is incredibly important because you can work really hard to save somebody's life and then have them die or have chronic lung disease or chronic fibrosis, all because somebody didn't wean their oxygen quickly enough. And it's a cumulative effect. Every hour that you're on oxygen, it's like you're aging the lungs. So if you can save an hour here and an hour there, the likelihood of the person leaving the hospital with better lung capacity has just improved. But every extra hour on that high FiO2 is bad for them. Time on 100% O2 is particularly bad. Even on 40% oxygen, there can be lung damage. So we continue to wean aggressively, even if they're barely on oxygen. There's no rule that says you have to be on oxygen if you're on the ventilator. Some people on the ventilator can be on room air if their saturations are within the range. So this can't be stressed enough. The third way oxygen hurts you is, you know that the air that we breathe is made up of 20% oxygen and 80% nitrogen. That nitrogen generally is stable between the body tissues and the air, so that your body tissues have about 80% nitrogen when you're breathing room air anyway, and the room has 80% nitrogen as well. When you breathe out and you say you have a small mucus plug somewhere, the alveolus absorbs the oxygen in that alveolus, and that will reduce the volume of air in that alveolus by 20% because that's the oxygen. But the nitrogen stays in there, so 80% of the volume is maintained, and that helps prevent microatelectasis. If you're on 100% oxygen and you get mucus plugging, then you get 100% collapse of the airway or lung distal to the blockage. And everybody gets little mucus blockages, particularly when they're sick with pneumonia or bronchitis. So being on high FiO2 actually creates atelectasis, which leads to more VQ mismatching, which leads to more hypoxemia. So that's 3 reasons right there to always be on the least FiO2 necessary to maintain the oxygen saturation in that 92 to 94% range. You've probably seen this before as well. If somebody has a simple pneumothorax, meaning a pneumothorax without an air leak, that air that is causing the lung to collapse is made up of whatever the patient was breathing at the time. In most cases, in someone admitted with pneumothorax, they were breathing air. Therefore, that was 80% nitrogen and 20% oxygen. It turns out if the air leak is stopped, which many times it is or stops very quickly, if that person breathes 100% oxygen for an hour or two, this will wash all the nitrogen out of the body, which will include the nitrogen that isn't making up 80% of the pneumothorax. After that 2 hours and the nitrogen is gone, the pneumothorax could shrink by as much as 80%. This is frequently used, but the standard protocol is to have the 100% oxygen particularly, by a non-rebreather or a CPAP mask or something like that, that 100% oxygen is only needed for 2 hours, because once the nitrogen's washed out, there's no more nitrogen to wash out. The body doesn't make nitrogen. It only gets nitrogen from the room. And again, if there's no air leak, the pneumothorax will not reaccumulate. If it does reaccumulate, it's because you had an air leak, and your oxygen therapy is not going to be useful. But it's worth a try on a fresh pneumothorax to have the person, if they're not otherwise having contraindications, to breathe 100% oxygen for 2 hours, and after that you wean them back to the minimum amount of oxygen necessary to maintain their saturation in that 92 to 94% range, which might be room air depending on the patient's circumstance. So it's worth a try. It doesn't always work, again, depending on whether there's an air leak or not. But again, there's no reason to do it more than once, and there's no reason to do it more than 2 hours. In actual fact, probably in 10 to 15 minutes, almost all the nitrogen will be washed out of the body. It may take a little bit longer to absorb the nitrogen from the pneumothorax space. The other place where high FiO2s are used is carbon monoxide poisoning, which is more of a wintertime thing as people get exposed from indoor space heaters that they shouldn't be using indoors. Carbon monoxide comes from products of combustion, so there has to be a fire somewhere along the line or impure combustion, and that carbon monoxide can displace oxygen. And using 100% oxygen helps get the carbon monoxide off the hemoglobin faster than it would happen breathing room air. And this could be done for a few hours, but beyond that, you again would need to wean the oxygen back to the normal protocol of just maintaining oxygen saturations in that 92 to 94% range. I should also mention that in carbon monoxide poisoning, if the poisoning is bad enough that the oxyhemoglobin saturations are in the 20% plus range and the patient is showing signs of tissue hypoxemia, meaning lactic acidosis, the gold standard is to use hyperbaric oxygen therapy. And in CO poisoning, hyperbaric oxygen therapy can have benefit even given 24 hours later, and helps improve the cognitive loss that can occur as a result of the carbon monoxide poisoning. And one last thing to mention about oxygen therapy, and this has to do with flying. Being here in Central Florida, we do have a fair number of patients who flew here on vacation for whatever reason or to visit family. And when you fly on an airliner, the cabin altitude is pressurized to between 6,000 and 8,000 feet. They're not pressurized to sea level. This means there's about 25% less oxygen based on millimeters of mercury available to breathe than there is at sea level. So if your normal PO2 is 90 and you have a 20% drop in your inhaled oxygen concentration, then that means that you're still in 21% oxygen, but the partial pressure is lower. So that PO2 of 90 may turn into a PO2 of 70, which changes your saturation from 97 to 94. Not a big deal for somebody that's healthy. But if your PO2 on the ground is 60 and you drop the available PO2 by 20%, which means another 12 millimeters of mercury, maybe then your resting PO2 is 48. Many patients at that level would just hyperventilate enough to raise their PO2 up over the 60, but that's not really a good and healthy solution. So in general, if you're trying to tell if somebody is good enough to fly back without oxygen, just as a general rule, if your pulse oximetry oxygen on the ground is 94%, you're probably good to go, because you have enough of a built-in margin with that PO2 in the 70s that you'll still be over 60 on the airliner, assuming you're not exerting yourself or doing push-ups or something. But we do have the ability in the office to do high altitude testing where we actually have the person breathe lower partial pressures of oxygen. We simulate what it's like in the airplane, not by lowering the pressure, but by just lowering the FiO2. But I found in my personal practice, if you just go with a 94%, how much ever oxygen on the ground is necessary to keep the saturation 94 plus is the amount of oxygen that should be used on the flight. So that concludes our oxygen therapy talk. Stay tuned for the next one. Hope you found this useful.